practice guidelines project for bariatric surgery guidelines. The instructor with us is Dr. Stavros Antoniou. Dr. Stavros is a general surgeon and a guideline methodologist with the European Surgical Endoscopy Association. He's the lead of the GAP project that produced the Agree-to extension for surgical guidelines, which is called now Agree-S.
Exactly.
The floor is yours, Dr. Stavros.
Thank you. So I'm Stavros Antoniou. I'm a general surgeon at the Papaggeorgiou General Hospital. It's a hospital in Thessaloniki, Greece, which is in northern Greece. I'm also the chair of the European Association for Endoscopic Surgery Guideline Subcommittee. So I'm going to keep this short because we are all healthcare professionals and we are all quite busy. So I'm going to present you the Agree-S tool, just the essence of it. And if there are any questions, either throughout, so feel free to interrupt me, or you can ask any questions you might have at the end of the presentation, whichever you prefer. But just if you want to interrupt me, just make sure that you switch on your microphone, because I will not be able to see the chat messages. Right.
I will follow the chat messages, no problem.
Great, perfect. Thank you, Yasser. I have to declare that I'm chief investigator of the GAP project. The GAP project is the project that led to the Agree-S tool. This is a non-financial conflict. I'm instructor at InGuide, the Guidelines International Network, and McMaster's program on guideline methodologies to train individuals to become guideline methodologists and chairs. And I have received a great scholarship. So the InGuide, the conflict related to the InGuide program is a financial conflict. Hopefully it has not influenced this work, and it will not, I don't think it will influence the presentation I'm going to hold today, nor the rest, I hope, but this is up to your judgment. So a few words about Agree-to and Agree-S. Most of you might be familiar with Agree-to, which has 3 dimensions. It's a methodological tool, a reporting tool, and an appraisal tool. There's a significant overlap among these characteristics of the Agree-to dimensions, but the scope of each one of the tools is different. So the methodological tool is meant to inform the methodology of guideline development, and it does not substitute established methodologies, but it is intended to summarize some common methodological features of tools available out there, and primarily the GRADE methodology. The reporting tool is similar to RIDE, shares some common features, and it is intended to assist in reporting guideline reports, guideline manuscripts. And the appraisal tool is unique, I think. It is a tool that helps people, different users, appraising the quality of guideline documents. So Agree-S was developed specifically for guidelines on surgical interventions. So we aimed to develop an Agree-to extension to be used specifically in guidelines on surgical interventions. So we established a consortium with different stakeholders, different people with different surgical backgrounds, different surgical disciplines, guideline methodologists, journal editors, patient representation as well, among others. We had the participation of Ivan Flores and Melissa Brewers, who are the leads of the Agree collaboration. And we named the project GAP. It was a tripartite project. I'm not going to elaborate on the specific features of the project, but it led to the development of a methodological, a reporting, and an appraisal tool specifically for surgical guidelines. And why? What was the rationale behind that? Surgical guidelines have some unique features. First of all, surgical experience and expertise play a substantial role, and it is a parameter that has to be taken into account when developing guidelines on surgical interventions. Furthermore, evidence from RCTs is more scarce than in the surgical field than in the pharmacological field. Furthermore, the infrastructures in terms of the organizations and health systems also play a role, because consider a guideline on, let's say, a guideline on whether to use a specific antibiotic for the management, for the treatment of pneumonia. You just administer the drug and that's it. But if we're talking about a surgical intervention, we need to know whether the infrastructures are in place. And this will define the direction of the recommendation and likely also the strength of the recommendation. So this is another characteristic unique in surgical guidelines. Furthermore, there are few experts in new technologies, and as you might also already be aware, new technologies or the technological field is rapidly evolving in the field of surgery. And there are few experts in new technologies, and this makes their participation in guideline projects unique, because on one hand they usually have some kind of conflict, usually financial, but non-financial conflicts are also strong, may have a very pronounced effect. And on the other hand, we need them on board because they are they have a broader knowledge around this specific topic. And last, there are limited cost-effectiveness studies, which you might, as you might already know, cost and cost-effectiveness are specifically important when developing guidelines. So the scoring principles in the AGRI-S appraisal tool, similar to AGRI-2, there's a Likert scale from 1 to 7. 1 indicates the lowest possible quality, 7 indicates the highest possible quality. And there's no correspondence between the number of the features that receive a high score or a score higher than a threshold and the overall score of the guideline. Okay, so the appraiser needs to take into account the global characteristics of the guideline in order to score, to provide an overall score. So at the end, the appraiser is called to, after going through the different domains and different items of the tool, the appraiser is called to provide an overall score. So let's move to the domains. Domain number 1, scope and purpose. And the first item reads, the guideline has been developed according to a protocol and the link to the protocol is provided. This is a new item. It is not included in the original agreed-to instrument, and the appraiser needs to check whether a protocol is in place, whether the protocol is accessible, whether there were any deviations from the protocol, whether these were reported, and whether these are justified. Just to note that deviations are methodologically acceptable, however, they need to be justified. Then the second item, the overall objective or objectives of the guideline are specifically described, and one needs to check whether there's a specific and clear objective that drives the development of the guideline. First, the objective needs to be reported, and second, there needs to be a clear rationale behind embarking on a guideline project. And this is specifically important because you might already be aware that several guidelines are being developed driven by the industry in the worst case scenario, or in the best case scenario, they are initiatives of individuals who have a specific expertise on a topic. So, for example, a guideline development organization might, in order to justify the development of the guideline, might explore the preferences of the target users regarding which topic needs to be addressed in an upcoming guideline. The third item, the health question or questions covered by the guideline are specifically described. As an example, the question framework, patient interventions, procedures, outcomes. So one needs to check whether the healthcare question is within the interest of the guideline, whether the questions are clear, whether they follow the PICO or similar structure. If not, for users, probably, so if the questions are not clear for users, then they are probably not going to be clear for developers either, and this makes the development of the guideline problematic. How were the questions selected? How were they prioritized? Was a survey performed or after discussion among the guideline panel? And if there's no direct link between the question and the recommendation, one needs to be skeptical. So you also need to check whether there's an alignment between the question and the recommendation, whether the recommendation directly addresses the question. The guideline was supported by a guideline development committee, including a guideline methodologist. This is also a new item. And we thought this is important because we know that the presence of a guideline committee, at least, if not a guideline methodologist, positively affects the quality, has a positive effect on the quality, overall quality of the guideline. And we have quantitative data on that. So you need to check whether a methodologist was involved, whether the methodologist was certified, and what exactly was his or her role in the guideline development project. And last, whether the guideline was developed with the support under the auspice of the Guidelines Committee. Domain 2, stakeholders. The guideline was supported by Guideline Development Committee. Sorry, this is not, sorry, I didn't, this slide is incorrect. We go to the next one. The Guideline Development Group includes individuals from all the relevant professional groups and patients. We need to make sure that all affected stakeholder groups are represented in the guideline, because these are going to be the target users, and involvement of a wide range of stakeholders ensures that the topic of interest is dealt with holistically. And in our experience as well, the participation of other stakeholders groups, except surgeons, is of paramount importance. Was representation balanced? So depending on the topic, was there an adequate number of representatives from different stakeholder groups? For example, if we deal with a guideline on, let's say, the surgical management of colon cancer, we need to involve at least two gastroenterologists, 2 oncologists. We cannot have, let's say, 5 or 6 oncologists, because there's going to be an imbalance justified, since it's a surgical guideline, it may be justified to involve a larger number of other stakeholder groups need to be represented, but there should be an equal representation among supportive stakeholder groups. Was a patient representative or advocate involved? Extremely important. It is only a recent advancement in the field of guideline development, at least in the field of surgery, that patient representatives are being involved. And what was his or her role? So we need to make sure that the patient representatives, the patient representative or representatives had a substantial contribution, and that their participation was not tokenistic. So the guideline development group needs to specify that the patient representatives, for example, were part of the panel from the very beginning of the project, from the protocol phase up to the conclusion of the project, and that they had equal rights, voting rights, for example, or equal opportunities to speak up during the guideline throughout the project. The target users of the guideline are specifically described. This is quite straightforward. We need to make sure that the authors define the target users. Are they surgeons? Are they other stakeholders like oncologists, general practitioners, patients? So this needs to be made clear. Then we move to domain 3, evidence synthesis. This is a new domain. We felt to highlight that every guideline needs to be informed by evidence synthesis, either from the existing literature, so systematic reviews, and eventually meta-analysis projects, the novel systematic reviews. So the first item of domain 3 systematic reviews to search for was the guideline based on a systematic review or more systematic reviews, new systematic review, an existing one, and was its or their quality assessed, the field of systematic review available, were correct search terms used and towards a search strategy correct, and were all relevant databases searched. Next item, the criteria for selecting the evidence are clearly described. Were selection criteria set in advance? Were there any selection criteria, and if so, were they selected in advance? So you need to check. If not the protocol, then the main document may report on that. We'll move to domain 4, development of recommendations. The views and preferences of the target population, patients, public, etc., have been sought. This item is unchanged from agreed to, whether patients or public representation was there a participation from patients or the public sector representatives from the outset? What was their role? So there's an overlap with the previous item, and what were their voting rights? The health benefits, side effects, and risks are considered in formulating the recommendations. Here we need to check whether harms have been considered, whether both beneficial and harmful effects were considered, whether observational studies were sought. This is particularly important because especially surgical trials, pharmacological trials as well, but surgical trials even more, are usually have a small sample size, and harms cannot be well quantified when we deal with small sample sizes. Furthermore, in randomized controlled trials have usually defined follow-up, and we do not have a long-term follow-up. For example, if we deal with the surgical management of colorectal cancer, a follow-up period in most trials might be around 2-3 years, whereas in order to quantify the so-called, if we can call them this way, harmful effects, for example, a recurrence, we need a longer-term follow-up, and this follow-up can be provided by observational studies in most cases. Are the harms well reported, and were they considered when making the recommendations? So did the guideline development group consider the balance between the benefits and the harms before making the recommendations? Next item, there's an explicit link between the recommendations and the supporting evidence. So we need to check whether there's a link between the evidence and the recommendations. What's the magnitude of the benefits and the harms? Was just evidence on benefits and harms considered, or the so-called in the grade context, the evidence to decision framework, which considers parameters such as patient values and preferences, cost, acceptability, feasibility, cost effectiveness, equity, etc. The recommendations are specific and unambiguous. Are the recommendations clear? Are they actionable? And where the setting, resources, and expertise defined? This is specifically important because the recommendations which use a complex language and may not be directly actionable, they cannot be actively used by target users. So a recommendation needs to be very straightforward. We recommend this or that. We suggest this or that, or alternatively, we suggest that. And the rest of the document needs to justify the recommendation. So the recommendation needs to be very, very specific and actionable. The setting, resources, and expertise defined are also of equal, if not of greater importance, because as we outlined before, the result of taking a recommendation into action depends heavily on the setting. So whether there are infrastructures in place, whether there are sufficient resources, and whether the one who implements the recommendation has the respective experience and or expertise. So these need to be defined in the recommendations. The different options for management of the condition or health issue are clearly presented. Are there any different management options provided, depending, for example, on disease stage, setting, expertise, experience, resources, etc. Key recommendations are easily identifiable. Also, unchanged item from agreed to. Can the recommendations be easily identified, and are they distinguished from the discussion on or narrative supporting the recommendations? And this item is specifically important because sometimes one can identify a recommendation or more recommendations in a guideline report, but if you read through the justification part of or the narrative, you see another or you identify other phrases which can be considered recommendations. So they might explain the context, and then the users should do that and that. So the recommendations need to be separately reported from the rest of the manuscript. And this is because ideally, if a guideline was developed in line with highest methodological standards, each word of the recommendation matters. Each word of the recommendation was selected based on very specific criteria And as you may already be aware, the use of words such as may, should, etc. is specifically reserved for very distinct settings. So depending on the strength of the recommendation, etc. The potential resource implications of applying the recommendations have been considered. One needs to check whether the required resources, both financial in terms of expertise or cost effectiveness, have been considered in making the recommendations. Consider, for example, a guideline on, let's say, robotic surgery, which might demonstrate a marginal beneficial effect to patients, or more pragmatically to surgeons because you have less fatigue, etc. But the same guideline does not consider the financial resources that are required because the robot itself is extremely expensive. So if we do not consider the financial implications, then one may be prompted to issue a strong recommendation, but this cannot be generalized to be implemented in the intended setting. Does the strength of the recommendation account for experience and expertise? This is particularly important for the reasons outlined before, and intentionally we repeat ourselves because experience and expertise play a great role in patient outcomes. And if we have, let's say, a strong recommendation for a complex procedure that can be performed by a minority of surgeons, if you take this recommendation and you use it in settings where this experience or expertise is not available, the effect of using the guideline may be harmful. Domain 5, editorial independence. The views of the funding body have not influenced the content of the guideline, so the role of the funding source needs to be defined. The authors need to declare whether there are any potential bias, and we are talking about both financial and non-financial bias. And there are opinion papers by leaders in the field of guideline development who support, and in my experience, I can confirm that that non-financial bias may have a great effect on the guideline development process. And I can share with you a recent experience where I participated in a guideline development project as panel member, and one of the members of the steering group was the author of an RCT that dealt with this specific question. And there was great pressure by this steering group member to provide a strong recommendation in favor of the intervention that was favored in their RCT. So we need to make sure that there are that non-financial bias have been declared. Competing interests of guideline development group members have been recorded and addressed. So the previous had to do, with the funding source, right, with the funding body. But what we have already outlined is what we discussed before, right? So we need to make sure that there are no non-financial bias or any kinds of bias with regards to the funding body and among members of the guideline development group, right? Okay, so domain 6, implementation and update. The guideline describes facilitators and barriers to its application. We need to consider whether barriers and facilitators were considered when developing the guideline, and whether there are ways to overcome these barriers, and these ways were discussed. For example, especially especially in the field of surgical interventions, but also in other fields as well, I guess. But I think that in the field of surgery, this might be more pronounced. Change, a culture of change is something that we do not encounter very often. So resistance to change, for example, is a parameter that almost invariably needs to be discussed in a guideline developed in a guideline on surgical interventions. A procedure for updating the guideline is provided. Every guideline project needs to set a validity period and whether any measures taken to predict when new evidence is going to become available. So we need to make sure that there's a date of expiration of our set of recommendations for various reasons, and among those, the most important might be the emergence of new evidence. So we need to predict when new evidence is going to become available. For example, the guideline development group might search for trials which are ongoing, or communication with leading institutions who might lead ongoing trials and discuss with them, investigate whether these are going to become available, or just see the trend of the evidence. And if we see that very few trials over the past few years have been developed in a specific field, we might consider that we do not expect new evidence to become available soon. Therefore, we can extend the validity period of our guideline. So we need to check that such an exercise has been performed by the guideline development group. The guideline provides advice and or tools on how the recommendations can be put into practice. So other tools to facilitate implementation of the recommendations provided, for example, patient decision aids, or visual abstracts, or algorithms, treatment algorithms, which also describe the alternative interventions. The guideline presents monitoring and or auditing criteria. This is quite straightforward, whether monitoring criteria are provided and auditing criteria, for example, reaching a specific threshold of beneficial effects or maximum thresholds of harmful effects. And this can be summarized, for example, by providing summary outcomes from published studies. And yeah, I think that was this was the last item. The scoring principles are the same as we've agreed to. There's a global score from 1 to 7. There are no prerequisites of a minimum score in specific domains, and no formulas are recommended to calculate the global score. And I'm saying that I'm highlighting this because there are several studies which have used agreed to with some internal rules. For example, in some of the domains, if the score is, let's say, more than 80%, then this guideline can be recommended for use. There are no such formulas. So you need to make a global decision on whether to recommend with modifications or not recommend a given guideline for use. Of course, depending on, there's a certain degree of subjectivity here, and I have to declare that the validity of AGRI-S has not been assessed yet. This is an ongoing project. We hope that within the next 2 years we will have the results of the validation of AGRI-S. AGRI-2 has been validated, so we do not expect any any major surprises there with Agree-S. But based on your experience and your involvement in the field, some domains might have a greater effect on your overall judgment on the global score and whether to recommend or recommend with modifications or not recommend a guideline. For example, the methodological rigor of the original Agree-2 might play a greater role compared to, let's say, the clarity of the presentation. But this is an individual judgment of each appraiser. You can also visit the Agree-S website, agrees.org, where you can fill and download online the Agree-S appraisal instrument, or you can download in PDF or Word format. And there's a link to the detailed guide on how to use the Agree-S appraisal instrument. And that was the presentation. I'm happy to take any questions you might have.
Thank you, Stavros. That was a very enjoyable presentation. I have a couple of questions myself, but I'm going to wait for the audience first, if anybody would like to jump with questions.
Hi, good morning. My name is Jose Menezes, and thank you for your presentation, but I just would like to know about the guideline protocol registration, the first item you described. When it comes to traditional clinical practice guidelines, we really struggle to find clear guidance on how to register the guideline before, right? To make it meaningful. So what's the difference in surgical guidelines? What have you noticed that made you create this new criterion? Thank you.
Yeah, this is a great question. There was no difference there, or any difference was not the main driver to develop Agree-S. But as we discussed with the leads of the Agree collaboration, we felt that irrespective of the scope of Agree-S, which is surgical interventions, we felt that registering the guideline and having a protocol in place before embarking on a guideline is of specific importance. And the reasons are similar to those when we deal with non-surgical guidelines, for the community to be aware which guidelines are ongoing in order to avoid duplicate efforts, or for example, with regards to the protocol, to make sure that there's transparency in the process, and making sure that the principles are followed. Yeah, but nothing specifically related to surgical guidelines.
Okay,
May I add something here about this registration issue? Because at the time of the early days of the Agree-2, there were no guideline registration agencies or organizations. But recently, there are now 2 international registries for clinical practice guidelines, the GIN and the Prepare. So, but at the old days, there used to be none. It used to be registered as a regular research protocol or a systematic review, but now there's an official guideline registries.
Yeah, correct. Yep. Any other question?
Hi. So I have a question. So if you look at the Agree-S online, it isn't divided by domains. And do you not want us to calculate domain scores for a specific guideline like the Agree-2?
Yeah, that's a good question. Perhaps this is something that we should introduce. So one would need to calculate domain scores to calculate domain scores individually, because it was not actually our let's say our intention to focus on domain scores rather than the resulting overall score. But this is a good suggestion. So there's no such option for now. Yeah, Dr. Dowidar. Yeah.
Yes. Thank you, Stavros, for the presentation. However, I have noticed a great similarity between Agree-S and Agree-2. So, is the intention for to substitute Agree-2 or to supplement it? And do you see this similarity a problem in the future, or how do you see it? Thank you.
That's a very good question. So there's a great degree or a significant degree of similarity, but there are subtle differences between the two tools. One of the differences is that first of all, we have several new items. If I remember correctly, 5 new items, and we have excluded some items which we consider are not that important or should not be prioritized in the context of surgical guidelines. On the other hand, we have rearranged items within the domains, and we have organized the domains differently compared to Agree-2. And this was based upon the second part of the GAP project, so GAP2, where we used statistical tools with the help of our statisticians in order to calibrate the Agree-2 instrument, and the results of the statistical analysis informed to a certain extent the development of Agree-S in order to increase the internal validity and the reliability of the instrument in the context of surgical guidelines. Yes, Amer.
Yeah, so it's just a follow-up question. I'm a bit confused. So I've worked a lot on Agree. So we have domain scores. With the domain scores, we could get if we have 4 people judging it or 2 people judging it, we could actually calculate a score per domain. It's suggested by Agree not to do overall scores. Some people do it, so I've been working with some groups who do it, some groups who don't do it. In this one, you said we don't want to do overall scores. At the same time, there's no domain scores. So it's just going to be per item score?
No. So first of all, because the validity up to now, we make the same recommendation as for the original Agree-2. So at least 2 assessors, and ideally 4 assessors should raise a set of guidelines. But to be honest, the website as it is now, it is intended to inform. It is intended to be used by target users rather than investigators, and this is the limitation of the website. So there are no supporting tools up to now to allow parallel use of Agree-S and work on a consensus among appraisers or calculate the mean score between appraisers. So these specificities have not been clarified yet, to be honest, but they will soon be clarified as soon as the validation project has been completed.
Okay. And so for now, you think we should just follow agree method? So for like in this project, you would suggest for us to use domain scores?
Exactly. So you can use domain scores, but domain scores are not going to be or are not supposed to be the main determinant of the overall score. This is the key message.
Okay.
Yeah. Yes, sir.
Yeah, just to confirm, so the equation present in the agree-to manual is not applicable to agree-S right now? I mean, I guess the same question. I mean, group appraisals using the equation in agree-to is not
Sorry,
applicable.
come again? I didn't understand.
The equation used to calculate the domain scores of the agree-to is not applicable to agree-S right now?
It is. It is.
It is. Okay, so we do have group appraisals.
Yes, but there's no software infrastructure to support this process.
Yes, yeah, no problem. We realized this. It's similar like the old days of the agree, so we can still do it manually. But I mean, the same equation applies. No
absolutely,
problem.
and this is also described in the publication related to the appraisal tool. This appraisal tool. Yeah.
Okay. I have another question though. Again, inspired by the using of agree-to. So there's a lot of reviews. When you have a huge number of guidelines, sometimes we filter them by appraising domain 3, which is rigor of development in agree-to. And I guess it's equivalent in agree-S is 2 domains, domain 3, evidence synthesis, and domain 4, which is development of recommendations.
Exactly.
So would you consider for agree-S these 2 domains? I know nobody states this, but it's like an observation that these are like the heaviest domains of all of them.
Yeah.
Would you say the same for agree-S?
Yes, exactly. But
okay.
Again, it depends on the context. It depends on the context. For example, if you know consider the situation where we have a scientific organization that deals with a very specific surgical field. Let me give you an example. Let's consider this a robotic surgery association. So if this association develops a guideline project and it does not declare the role of the sponsor and the funder, and this role has not influenced the process, the guideline development process, then this domain of editorial independence may be the main determinant of the overall score and the final recommendation, whether to recommend this guideline for use or not. I hope this was clear as described.
Yes.
And I agree. In most situations, the evidence synthesis and the development of recommendation domains are probably the domains which carry the most weight, if I can say so.
Okay, and I have another one, please. I mean, again, similar to agree-to and agree-Rex. When the agree-Rex is out, now it is said that, okay, this is not a substitute, it's not a replacement for agree-to, it's a complementary tool. So you have to use both together. It doesn't go that you use just agree-Rex. So similar, if we talk about agree-S, are you saying the same, that it's only complementary to agree-to and you have to do agree-to with it? Or it's completely independent and we can do agree-S without agree-to?
Yeah, this is something that I also wanted to make sure this is clear. So there are surgical guidelines which do not deal exclusively with surgical topics. For example, let's say the use of low molecular heparin in the perioperative period, right? So there's a pharmacological component. So for this part of the guideline, we recommend using agree-to because several parameters, several items of agree-S are not applicable. So, for example, the item on surgical experience and expertise does not play a role here. It's just whether the question is whether to administer or what dose of low molecular weight heparin to administer, right? So there's so if we have guidelines with mixed let's say questions, surgical and those involving a pharmacological components, one should use agree-S and agree-to in a complementary fashion. Yeah. Jose, there's a question, or Yasser, I think you have your hand up. I'm not sure if you have another question. Oh, sorry. Yes, Jose.
No, thank you. Yeah, but about that complementary role you mentioned, how feasible in terms of resource use is the application of agree-S, even when considering that you mentioned 4 independent researchers pricing the guideline? I think that rule of the 4 researchers is quite hard to meet, actually, and we always end up, we end up with 2 researchers, 2 independent ones. And I think that's the most likely scenario. So that's something that should be reconsidered. I guess, or I don't know how you plan to articulate the 2 instruments.
That's an excellent point. That's a very, very good point. So we need to consider this pragmatically. So, and I completely agree with you that 4 appraisers are too much. You cannot articulate such a group dealing with a large number of guidelines. So I cannot give an answer before we have the results of the validity assessment, to be completely honest. Until then, we have to recommend what agree-to recommends. It's 2 and eventually +2. But I completely understand, and I agree with you that this may not be feasible. But this is something that we will do in the context of the validity assessment. But in any way, I understand that this cannot take place in other scenarios very easily. Understand is difficult. Yeah.
Thank you.
So I see there's a question in the chat from Rokaya. I have a question regarding domain 3. When the developers, for example, don't run a systematic search, they only depend on systematic reviews which were developed also by the same authors. The question is this considered some sort of bias? Right. So it is completely acceptable to use existing systematic reviews, but there must be some sort of quality appraisal. So, for example, using the what is it called, the instruments, a specific scoring system to appraise the quality of systematic reviews, which is called AMSTAR.
Yeah.
So this is a way to get around that. Do not claim this to be universal guideline methodology. Is that one cannot have the full control of the
I think there's an interruption in the internet.
Hello, and apologies for.
Yes, you're back. You're back again. Good.
I was just saying that this is I declare this is my personal opinion, and this does not reflect the opinion of grades and nor ring guide nor the community of guideline methodologies. But one cannot have, my opinion is that one cannot have the control of the quality process of the systematic review, so how well a systematic review was conducted, and every part of the systematic review process, for example, the assessment, etc., unless they do. This is why within the European Association for Endoscopic Surgery, from a systematic review de novo, we have people on board who were trained to do that, to do the evidence search and the evidence appraisal. And I'm happy to introduce to you Bright Huo, who is a great collaborator. He's facilitated this process among a couple. So if this is not being done by the guideline developers or an ad hoc group employed by the guideline developers, then we can learn about the quality of the existing systematic review. And of course, you know, there are many systematic reviews out there which are of extremely poor quality, right? So can you trust them? I personally don't. And if I would, then I would probably rerun the risk of bias assessment part because this is probably the Achilles heel of guidelines, to be honest, according to my opinion. Yeah.
So Stavros, I mean, going back to your comment, you mean you would recommend before including a systematic review to evaluate it by AMSTAR 2, for example, or just see if they followed the grade methodology and that's all, or?
Yes. So using any kind of appraisal tool for the systematic review that it is being used. So this is, and you know, if I would appraise the quality of a guideline using AGRI-S, I would definitely check whether the quality of the systematic review considered was appraised before using it. Yeah.
Sorry, doctor. To complete my question, is it proper that they, from the transparency concept, that they do not run a systematic search, and then if this systematic review appeared in the systematic search, they can include it, but they cannot choose one systematic review, for example, and they depend all their recommendations depending on this. This is my question. Is this a sort of bias because they are building a systematic review just to say their, for example, their opinion or gather the information? As you mentioned, also the quality is very poor, so they are just trying to formulate their systematic review in a proper guideline recommendation so that everyone can follow it.
Yeah.
Because it's a guideline, so.
Yeah. Well, it depends on the context. So, for example, if a systematic review on a specific topic is recent enough, then this is one of the parameters that will define whether it is acceptable to consider this exclusively or not. So, for example, it is acceptable for a topic where we do not have in a non-rapidly evolving field, it is acceptable to use an existing systematic review, even if it is dated, you know, if it's 1, 2, 3 years old, unless there is, in a scoping search, you see that there are new trials which might affect the overall effects presented in the systematic review. For example, if you might be aware that WHO and other groups developed rapid recommendations published in the British Medical Journal. If these authors used on COVID-19, right? If these authors used a systematic review, an existing systematic review that was published, let's say, 6 months earlier, this would not be acceptable because there were new trials every month, if not every day, right? On some occasions. So it depends on the context. In the context of surgical, in the surgical field, usually we do not have significant new evidence published over a 1 year period. So a systematic review published within the last, within the last 12 or 16 or 18 months might be acceptable. Yes, Jose?
Perfect. Thank you so much.
Thanks. Sorry, I also wanted to ask you whether your question was addressed, but hopefully it was.
Yeah, it was. So it depends on the discipline or on the topic or on.
Exactly.
So we can decide.
Exactly.
Thank you so much.
You're welcome. Yes, Jose?
Yeah, thank you. I think that one of the main challenges with deciding whether or not to conduct a systematic review de novo is that we don't conduct any risk of bias assessment in guideline development, right?
Yeah.
I mean, for the systematic review, AMSTAR is a methodological quality assessment tool, which is not related to risk of bias. So we don't know the risk of bias of the systematic review we are working with. Okay. And that's one of the things we first need to declare, right? Or be clear about. I think that's one of the main struggles. And at the end, it's okay. We just report that it's just a quality threshold. And we decide, we take it, we leave it. So that's it. I think it's not a big deal, and it's up to the panel, up to the GDG to decide and be transparent on the process behind the decision. I think that's it.
And these are great points. And of course, this discussion, overlaps or involves both the methodological part and the appraisal part. The methodological dimension and the reporting dimension of AGRI-2 and AGRI-S. But in my experience, because I've worked a lot with systematic review for a long period of time, with guideline development as well, I can say that relying on risk of bias judgments of the original of the authors of the original systematic review that is being used in a guideline project, relying on these risk of bias assessments might be misleading, because typically systematic review authors systematically underestimate the risk of bias. And being subject editor in our association's journal, I receive like 30 systematic reviews per month. And I can say that sadly, less than 1% of these guidelines, of these systematic reviews, use risk of bias assessment tools appropriately, right? Any further questions?
Stavros, I have one question related to our project specifically. Actually, I wonder if I can take advantage that we have 4 surgeons on board, because it's a debate. Maybe I asked about it before, about the inclusion criteria of bariatric metabolic surgery guidelines. So actually, right now we have 82 eligible or included guidelines. One problem we faced with endoscopic guidelines. So actually, we found sort of 2 types of endoscopy procedures for bariatric, for obesity. One done by medicine people and one done by surgical people. I mean, internal medicine do upper or lower GIT endoscopy, and surgeons do different type of endoscopies. So my question is, should we include any endoscopy procedure? Because this is not specified in the inclusion criteria. We have 10 items, but endoscopy was not mentioned. Nor mentioned, nor included or excluded, sort of vague. So I'm sort of,
In my opinion, this is a justified deviation from the protocol, and I would strongly support including these interventions as well, because these are interventions. It does not matter whether, and they require expertise, they require experience, they require specific infrastructures. So it doesn't matter whether the interventionalists, if there's such a word, are physicians and not surgeons, but they perform an intervention, right? It might not be called a surgical intervention, but it's an intervention that shares common features with surgical interventions. So it's an intervention in the human body, and these interventions require experience and expertise, specific infrastructures. So I would support including them, and of course, AGRI-S can be used for appraisal of these guidelines, guidelines on these interventions as well. Yeah.
So does Professor Nabil and Dr. Samer agree on this? Do we have a consensus from our surgeons? I'm not a surgeon myself, so I can...
Yes, I completely agree. I think all interventions should be assessed through the AGRI-S tool. I think the one item about experience is the most important in the new AGRI-S tool for any intervention.
Somebody has his mic open.
Did everyone hear me? Yeah, I think it should be included. I think you could, when validating the tool, you could use it for all interventional studies and guidelines. So even for, let's say, neurosurgical intervention through radiology or anything, this is very important because experience and skill play a major part.
So I'm not sure if there was because the connection was not very good. I'm not sure if there was any question on that or just a comment on agreement. Apologies.
No, just a question about whether to include the endoscopy. So I guess you recommend including them, and Samer does. I'd like to hear from Professor Nabil too, if he's still around. Professor Nabil agrees, so we'll include them. Okay.
Dr. Yasser, I agree. I agree that with Dr. Stavros' opinion that as long as it is an intervention requiring expertise and tools, it could be included, and it could be made clear in the protocol.
Yeah.
Yes.
Okay. Thank you so much. Thank you so much.
Great. Any further questions or comments?
Yeah.
Great. And if not, can we conclude?
Yes. Thank you so much for this outstanding presentation, and these discussions have been very, very inspiring and fruitful, I think. And we will use these as a reference later on.
Yeah.
The recording with all of the attendees.
Thank you.
Thank you so much, and thanks for all of the attendees.
Invitation, and really, I always really enjoy these discussions, and these discussions are always really insightful, and they also give to me another point of view or another aspect of the field of guideline development. So thank you as well for participating. So goodbye everyone from Greece. Thank you.
Thank you. Thank you, Stavros. Thank you, everyone.
بقى هم مشكلة هيسجل عشان كده ما